This isn't your grandma's cancer show.
Not your grandma's cancer show.
Hi, I'm Tatum, and today we're talking about queer sex after a cancer diagnosis. Because here at Not Your Grandma's Cancer Show, we want you to have a sex life that you feel great about. And a lot of the information out there is for heterosexual couples, often older than 70 that have been in long-term relationships. So we're going to remedy that. And so to remedy that, I've got two amazing guests here with me today. I've got Stewart O'Callaghan, and they've been on the show before. They run Live Through This, a cancer support group for LGBTQI plus community. And Lizzy Scott, who is a radiotherapy specialist who has great recommendations for sex toys. I can't wait to get to that bit. And is also working to make radiotherapy more queer inclusive. So welcome back, Stewart.
Hiya.
It's always lovely to chat with you. What was going on in your sex life when you were diagnosed with cancer?
So at that time, I was living in Germany and exploring a new city in all manners of the word. Mm-hmm. So it was a really nice way to sort of, be going out and sort of going on dates, and seeing where things went with people, which I think Berlin of all cities encourages. I was probably on the more shy side of things than the city expects, if I'm honest, but still getting out there.
And how did you feel after you were diagnosed?
It was a big old shift because you go from having this kind of freedom and this hedonism to sort of just focus on seeking pleasure in people, and then going into this very sort of inward focused thing about me, my health, what I was capable of. And I think there is also a really big shift that I had to reconcile, which was feeling like a burden, or that somehow because my life had become complicated, it was too complicated to sort of connect to other people. And I think when you don't have like a long-term partner that helps you sort of through those early stages, you can get really stuck in that point for a while. Even when I was starting to see people, I remember even one person telling me that they weren't sure if they could date me because that I might die on them. So, so you very early kind of get this real sensitivity to be like, how much can I share basically with this person, and weighing that up between how long do I think this person I've just met will be in my life for? Is it a very quick thing and I can be very private and I don't have to share much, or do I want to be more open? And I think over the years I've really played with both ends of that spectrum, and I think still struggling to figure it out.
Yeah. Oh, relationships are not easy, are they? We will get more into those. But that idea about what to share, like that also comes up with what to share with our medical team and what we feel free to share. And I know that you and Lizzy have done a piece of work together, actually. So, Lizzy, you're a radiotherapy specialist. Can you tell me a little bit about what got you into radiotherapy and why you wanted to work to, do a new intake form that made everyone feel more welcome in the space?
Sure. So it was a new way of actually asking pregnancy status of radiotherapy patients in an inclusive way, which meant that we actually asked all patients aged 12 to 55 when they attended for a radiation exposure what sex they were registered at birth. And the form actually also mentions intersex as well. So if someone wants to discuss that with us, in private as well. And then from that question, we would then ask anyone who answered female and or intersex if there was any possibility that they might be pregnant. And the idea was to make sure that our radiographers were actually being inclusive in their language and communication with all patients, not making assumptions about how people identify and what genitalia they have, and just making sure that people sort of knew how to have those conversations with patients, and that anyone who attended the department was included. So it actually was a piece of work that we did with the Society of Radiographers. Stewart did a really great job of sort of giving us the patient point of view as a trans person, and giving that voice from trans, non-binary and intersex communities. So we actually did produced the forms. We ran pilot studies in 3 different departments that were also diagnostic as well as therapeutic. So that's sort of plain X-ray, CT, as well as actually giving radiotherapy. That Stewart also took those forms and took them to different trans groups, non-binary, intersex groups. We also had an intersex campaigner, Valentino Facchetti, who I think had a little bit more media presence recently with all the amazing intersex inclusive pride flag they've made being displayed on Regent Street in London. And they did a really great job of helping us make that guideline more inclusive as well. And it really was a great project that meant that we sort of produced this really quite detailed, comprehensive guidance that sort of shows radiographers how to make their practice generally inclusive, how to approach a really sensitive question about pregnancy, which can be quite upsetting for a lot of people, no matter what their gender is. And sort of just make health professionals more aware that this is something we need to be inclusive about. And it has been pretty well received on the whole. And it's hopefully a lot of other departments are starting to pick up on it and use the forms and the guidance we've produced to improve their practice as well.
That's brilliant. And because that's really the beginning of, I mean, although we're talking about sex today, right? And, you know, especially sex after cancer, because it's that fusion of sort of medical and personal, and it's tricky for anybody to talk about sex. But when you're not represented on a form, or when you feel excluded, like I went for a talk about, once I came out of like my immediate chemo haze, I was like, okay, what information is there out there? And yeah, it was like, oh, this isn't for me, you know? And that idea that even on the form that you see an acknowledgement of yourself means that that's the beginning of the conversation, that's the beginning of the communication. And can radiotherapy affect somebody's sex life?
Oh, 100%. So anyone who's having their pelvis irradiated, they will find that their sex life will be affected, just because whatever genitalia and organs you have, radiation will cause effects. So I mainly focus on talking to people who have vulvas and vaginas about the side effects from radiotherapy, which can, with vaginas, include stenosis. It's when the vagina shortens and shrinks. It produces less natural lubricant. Your orgasm can change. There's not actually enough research about that, but there has recently been a paper in basically suggesting that the dose that the clitoris receives probably does mean that your orgasm will change if it's been irradiated. And we know that can cause issues longer term. So what we do is give people with vaginas dilators to actually, it's like a form of physiotherapy really, to help retain the vagina's natural shape, to actually exercise those muscles. They're basically plastic tubes that you insert inside, and we give them lubricant to do that with and advice around that. But as I'm sure we're going to end up touching on, it's not really perhaps sufficient information to give these patients. And with patients who have a penis, they're going to find probably that they're going to have problems with erection. Both anyone with any set of genitalia organs will likely have some issues with bowel and bladder frequency, potentially incontinence, which obviously can impact on your sex life. Yeah. And as I think Stewart has experienced themselves, fatigue is just a major issue in terms of just libido and sex drive, and obviously self-image, and just going through the psychological impact of having any kind of cancer treatment.
Yeah, and I see really Stewart nodding away there.
Yeah.
Yeah. What other ways, Stewart, does having a diagnosis and treatment affect sex really, and drive, and sexual wellness, sexual health?
Yeah, I mean, all those things, especially Lizzie touched on so many key ones. And I think there's other things like, if cancer and its related treatments changes your body, so it changes your body image in that way as well. So if you end up with a stoma, if you end up having a breast removed, so there's a lot of things around that. I think it's also as well about, I've definitely supported a lot of patients who have had cancers in sort of intimate areas, and then they find it really hard to shift from thinking about that part of their body in a clinical way back into a sexual way.
Yeah.
Because they've had to sort of think about it almost as this problem area for a while, and also have a lot of people kind of look at them in ways that don't feel very intimate either. So, as part of that examination and checkups, and there've been people who've just sort of contacted me as well, usually asking for advice too. They want to know how safe and how soon they can return to anal sex.
Yeah.
And there was one patient that I supported who came through our peer support network, and he had anal cancer. So sort of was dealing with that idea of how do I erogenize to the zone again, but also how soon can I return to anal sex? And we, from a charity perspective, tried to give him, the answers that are there, but we have to be professional. And he ended up sort of trying to find additional support and ended up contacting another patient in America. And that was the first time he got to have a real conversation where he got to speak frankly about these things. So I think what you were saying earlier, Tatum, about the importance of even intake forms being inclusive, it sort of sets an environment where someone's like, okay, you understand who I am, respect who I am, and that I can have those conversations, because there's definitely, the environment itself is, pretty clinical. There's a lot of power hierarchies that's sort of unspoken. There's this idea of how can I get my clinician to talk about something that, let's be honest, general society isn't really comfortable talking about.
No, nobody is really. And they're often quite uncomfortable.
Absolutely. And that conversation is super important, because it's about outcome mapping and sort of projecting together about what changes can be expected. And that can help someone understand the changes that are going to happen to their body as they're happening and how to recover afterwards. Whereas if you're promised that it's all going to be fine, you might come out the other side and be upset when you realize there's quite a few differences that can happen. Yeah.
And one of the examples that when we were chatting before that you gave me that I thought was really interesting was that how your preference, you experience pleasure during sex can actually change what kind of help that you can get. So can you tell me a little bit about the penile implants?
Yeah, so this is something that's really interesting. So when we think about erectile dysfunction, which comes quite a lot with prostate cancers, either due to radiotherapy or surgical removal of the prostate, things like that. And there are some modernizations of surgery where they leave a little bit of the prostate there if it's safe to do so, that can kind of help. But usually when it gets discussed and you read the information, it's very straight, and it's very about take an erection-related pill or like a penile suppository, something like this that will help you. But generally those kind of erections you get, or by pumping, won't ever be strong enough for anal sex, because anal sex, you need a bit of a firmer erection, right? So if you go looking online and you find some information, what you can actually find is there's very active forums and groups of gay men who have the penile implant instead. And that gives them the firm erection that they need, but also it allows them to almost erogenize that part of the body in an entirely new way. So yes, they may have lost some sensitivity, but they actually gain effectively an erection that they can keep as firm as they want for as long as they want. And they can go into these spaces, and it's really empowering to read them actually be proud of it and be proud about going into these sort of sex positive environments and being proud about how many people they can have sex with and the attention that it brings. So it's this thing of understanding that sometimes the standard therapy may not work for you and the kind of sex you're having. So being able to be honest about this stuff, especially if you can get aligned with a really fantastic nurse, doctor, or psychosexual therapist, and then really, again, mapping in that idea of what does good sex look like to me and what do I want to aim for?
Exactly, because somebody else might be like, you know what, I'd pick sensation every day of the week, you know what I mean, rather than length of time. And so actually that does really matter, like when you think of, you know, what kind of outcomes you can have. And so, Lizzie, I mean, I know there is sexual health, but like there is... My personal experience is a little bit like, okay, you've had cancer, like, get on with it. All my doctors all knew that, like, I couldn't even have a smear test, that to me, I felt I was sexually dysfunctional. I know other people might not look at it that way, and they might not have sex the way I was used to having sex. But for me, for like my kind of scope of things, I felt incredibly broken. But I felt that was kind of, just one of those things, really, and that I just needed to get on with it. From a clinical standpoint, is sex really part of a quality of life that is supposed to be looked at?
100%. I think the problem is we don't always practice it. So in research, and not even just research, it's probably not taught so well in medical schools and in other health professional degrees, but certainly health professionals are aware that it's incredibly important to people's quality of life. A lot more studies are done now with what are called patient-reported outcomes, where questions about people's sex lives will actually be recorded in relation to their cancer treatment and the outcome of their cancer treatment, long-term side effects, that sort of thing. So it's definitely recognised as being important to someone's quality of life. I think, unfortunately, at the moment, it's just very clinician dependent on, one, how much information you're given when you're consented to a certain treatment, and two, what the level of aftercare and advice is that you receive in relation to sex once you've had treatment. And that shouldn't be the case, especially in terms of if you're really getting informed consent in relation to treatments. You should have the whole picture on what exactly that treatment's going to do to you. I think it's definitely getting better. I noticed that more of our clinicians are writing those things, such as stenosis, on the consent forms for our patients who are having things like cervical radiotherapy or rectal radiotherapy, who have vaginas. They're certainly writing down erectile dysfunction a lot more for our prostate patients who are having radiotherapy, and they're definitely discussing it with them. But I think there's still a lot of reluctance there. I think that health professionals don't receive enough specific training on how to communicate about people's sexual health. And I think that the signposting is very poor. And it's incredibly difficult as a radiographer. You sort of have to be very proactive in wanting to go out there and learn about these things and find out what's available for patients. And it's sort of like, for myself personally, it's been something that I felt quite clumsy about. And I felt that I really had to try and read about myself to work out what's the best way of discussing this with people. What can we offer people after radiotherapy?
And what kinds of things are available? What can be offered? Because I think that's some of it, right, is that, like, when you're thinking about, like, should I even bring this up? I mean, I think what I'd love people listening to this to take away is that actually it is really important. And that, like, your doctor may not know, but it's still worth bringing it up because it is still, like, a factor. And there might be something that can be done rather than maybe not getting that information at all. So yeah, I'd love to hear, like, if, as a result of radiotherapy, like, what can be put in place? Who would someone ask to go see? Or
yeah, absolutely. So I would say, for example, pelvic radiotherapy, certainly in my department, and I would hope in most departments in the UK, you would be given some kind of specific information if you had a vagina that would usually involve dilators and education on how to use those. And sort of as part of that information, there's probably information about pelvic floor exercises, general pelvic health as well. And usually as part of that conversation, it's, do you have your contact your clinical nurse specialist? They are trained in these too. You can discuss them in future. They will follow you up over the next sort of course of years, and they should be checking with you and asking about those. That they're also the people who are capable of making those referrals to psychosexual therapists who can give you more specialist advice if sex is something you're struggling with. From a queer point of view, there is definitely a massive lack of information, and that's where charities like Live Through This that Stewart runs are really filling that gap. And it shouldn't necessarily be the case, but and I certainly still advocate talking to the clinician about your sex life if you're queer. It's just, I can understand how difficult that can be for people because fear of discrimination. It's really difficult when you have to explain to someone who's a cishet person how you have sex.
Yeah.
It's just this assumption that what other sexes other than penis and vagina, actually having to explain that to someone is incredibly difficult. So I can totally understand from a patient point of view that that's a big obstacle. But keep asking because people are getting better. One, if you ask a health professional about help with your sex life, I would be absolutely horrified if they didn't at least offer you a referral to something else, even if they weren't able to help you with the problem. And I do think most health professionals would at least say, no, but let me talk to someone else who might be able to help you with that problem. And then beyond that, I would say look at the different charities around that are there to support you. So obviously Live Through This, but also charities like the Eve Appeal, Joe's Cervical Trust. A lot of those charities are a lot better at signposting to specific help. Even things like breast cancer care. Actually, recently I looked at one of their leaflets, and they actually have how to masturbate in their leaflet with diagrams and everything, which I thought was
Excellent.
Great. Yeah, so it's definitely improving. But I wish that every clinician that you met on your cancer journey asked you the question about your sex life.
Yeah. I didn't know that there was a nurse that could help with dilation. And I was 10 years post-treatment. And, that is a long time to not...
I'm really sorry that you have to go through that.
It's, but I think for other people, like, even if you are years and years out from treatment, even if it is kind of... Because I think what happens is sometimes, you're tired, right? Like you've been getting through everything else, and sometimes we don't even prioritize our own pleasure, right? So it's really challenging then to kind of, want to prioritize it in a healthcare setting. But I did meet my nurse, and it's incredible. Like, it worked. Although some of the things that she recommended, kind of getting onto like the dilators, I got the really, really hard plastic ones. They were not so appealing. But I have seen since that there are fancier, soft silicone ones, much more fun colours as well. But the best bit of advice that I got, which again was almost like a permission, was to think about it as rehab and to get a really good vibrator. And the idea of a nurse telling you that, like, it changes something in your brain, as well. And so I think there can be a combination of, for me, when anything was inside me, it felt like broken glass. Anything, like I couldn't do anything myself. Like it was just a no-go, nada. And the combination of kind of permission, a strategy, and then thinking of it like rehab, that you don't need to be like even super turned on. Like you can just have a vibrator there and think of it as bringing blood flow into that area. And that reconnection with the blood flow in your brain starts to bring you back into your body a bit. And Stewart, have you heard of other people kind of having a similar experience with that?
Yeah, absolutely. And I think that reconnecting thing is so smart, a way to put it, especially when we think about if people have had surgeries, right? So nerves get cut, and sometimes it is that aspect of actually rewiring your body and understanding what it feels like now. Have you had lost sensitivity? Is it sensitive in certain places? And these are really important things to figure out, not only for yourself when you're doing this sort of personal rehab and physiotherapy through sex toys and erogenous zones, but also then when you share it with partners, and whether that be long-term or new partners, so that you are able to set boundaries and real hard consent lines about what's going to happen, so you can relax into the moment. There's nothing worse about going into a sex environment or a sexual sort of interaction and then not knowing how far it's going to go. And if you're feeling particularly uncomfortable or you're feeling very sensitive in a certain part of your body, establishing those things early on is crucial. And then in order to establish them, you have to know them yourself. Yeah. So exploring your body is a really good way to sort of bring that back. And it, as you said, it may feel a bit unusual in the beginning. Yeah. I definitely felt the same when you move from that almost out of that patient mentality back into a person, which is a gross oversimplification, but it's that idea of, oh yeah, I can have pleasure again. It's not all doom and gloom. Like, I'm going to live through this. I get to actually carry on. And actually, I was having this similar conversation with a patient. No, not a patient, actually, just someone in my friendship network. And she's a trans woman. And she put it really, really nicely, where she said, it's okay to get pleasure from places on your body that don't bring you joy. And I thought that was such a really nice way to put it, because there are times, especially post-treatment, where you are frustrated at parts of your body and you're angry about it, or you don't understand why, for example, your treatment path didn't work as well as somebody else's, or why you've got these long-term issues. But it's okay to have that and to grieve that and be frustrated by it and work through it. But at the same time, that shouldn't be sort of an all-out block on you seeking pleasure and exploring what your sexual wellness looks like moving forwards.
Yeah. And Stewart, you mentioned someone who was grieving how their sex life looked before, in terms of being able to kind of, not think twice about going to a bathhouse. Can you talk a little bit more about that?
Yeah, I think there is this idea, isn't it, where everybody kind of assumes naively when you get cancer that you just go through it and then you get out the other side. And I think everyone around you assumes that as well. As as patients, it's always, are you good now? Are you fixed? Is everything done?
You're all good, all better.
Yeah, and it's exhausting. And it's also really tricky, because then cancer does affect you in so many ways. And when it affects your sexual wellness or your activity, that can be pretty frustrating. And then especially, as a queer person, where part of your identity is how you have sex and who with and how you share that part of your body. So then moving forwards with that and having to almost reestablish that. And I think sometimes the cultures that people engage with sexually can sometimes be a bit tricky. So if you are into sex clubs or hookup culture and things like that, it's also how do you navigate those spaces after your health, right? Or even if you have a long-term partner, having that conversation, how do you almost go back to the start and talk about consent and these things? And I think it really comes back to that idea of conversations and consent. And also, as Lizzy's touched on as well, is having frank conversations as early as possible with your clinician, just so you can kind of map what these differences will be. And if you're struggling to have those conversations with your clinician, see if you can get referred to a psychosexual therapist who's much more comfortable with this stuff. We'll have a little toolbox of sex toys, and we'll talk you through things that might also help you actually get to where you're going to, but just add in a little tool that's going to help you get there. So say, for example, you've had a shortening of the vagina, and so deep penetration is just not possible. It's very painful. There's these things called O-nuts that are silicone rings that slip onto the base of either a dildo strap-on or penis that can act as a cushion. So again, you can relax into the moment. And it's that idea of sex should be not only fun and positive and reaffirming, but you should also be able to relax into it. And feel nourished by it. And you should never feel that you have to engage in sex to keep the interest of the people around you. It should always be on your terms and your comfort, especially when you've gone through something that really does change the way that you see your body. And I think the other thing that sometimes gets missed is because we focus a lot on the groin, right? And there's also the idea of non-penetrative sex, which is absolutely something to explore, especially if you've had something that's led to stenosis or vaginectomy or something along these lines. And the other thing as well is, I think Lizzy touched on it, is about your chest as well. So there's some research out there that says, when people go for reconstruction, say, making sure that you're going into it for the right reasons, that you understand that it's for you and your body and it's not for other people to find you of merit or interesting. It's about what makes you feel good, so you can stand confident in your body before you share it with others.
Yeah, and there's so many assumptions about that, isn't there? And that's something that we've covered in some of the Shine Connect conferences is, you know, it can be tricky because, again, there's these assumptions that when you're queer, you don't necessarily fall into. And if the doctors have presumed that you want a reconstructive surgery, when actually that person, you know, might be non-binary, might be trans, and actually it's like, no, I'd like them both to match, and I would prefer not to have either of them, you know, because that would make me feel more comfortable.
And we've had exactly that thing, and we've supported exactly that patient. And we've also met countless patients as well at this point who have had top surgery and had a lump identified during that procedure. So where these things intersect is quite often, to be honest, you know.
Yeah.
So I think when people think about our queer identities, I see it as like a shadow of Section 28 in the UK, but I think a lot of people feel like their identity doesn't matter and it shouldn't be in important discussions, and you should just focus on one thing, which is your cancer. But you should absolutely bring your full self into care. Clinicians are always talking about personalized care now, and part of that is really understanding who you are and how it's relevant. And being queer does cross over with cancer at multiple parts, whether it's your intimacy, your support network, your treatment pathways, so many things. So open conversations, even if they're a bit awkward in the beginning, can really, really be restorative.
Yeah. And, you know, as you were talking, I was also thinking about, you know, we've got like the physical sort of barriers of surgery, radiotherapy, chemical chemotherapy, fatigue, you know, and stress, the stress of sex. And, you know, some people like stress makes them horny, right? So some people actually get even more frisky. Hats off to someone I knew that was like going out and having threesomes during chemo. I was like, oh, you go, like, brilliant. You know, we are all so different. There's also a podcast actually, not queer, but talks about the desire for sex, called Dying for Sex. And, you know, you have all these different barriers, and then of course you have hormonal ones. So if you're on hormones, maybe because you're trans before treatment, that there might be a change to that. There may be, you know, I mean, so many different hormone centers, whether that be thyroid, adrenals, you know, your pituitary gland, like so many different things can affect. And particularly with trans people, having that I mean, everyone suffers with hormone disruption, but that idea of it actually tapping into your identity as well, you can't go through treatment without acknowledging that. And it feels like something that you would feel more, if you understand that your team understands, that makes a really big difference.
Absolutely. And I think you've touched on a really good point as well, because it's another intersection of identity and cancer, right? So this idea of medical transition, taking hormones, and how this can be affected. So sometimes the hormones some people will take will be quite similar to the hormones used during cancer, during medical treatment. So things like androgen deprivation in prostate, things like that. So there might be some similar sort of things to discuss there. But also, again, why I advocate for trans healthcare being kind of central healthcare rather than this sort of fringe healthcare, because it crosses over in a lot of spaces. And also, as you pointed out, sometimes if someone's diagnosed with cancer, there can be issues with their gender therapy and whether the taking hormones might actually be driving the cancer if it's particularly receptor positive. And with that as well, there's, you know, I've supported patients who get very lost in the middle because cancer moves so fast and gender system does not, as we all know. So they get left in the middle with not a lot of information. And especially if it means then that cancer wants to pause the medical transition and pause their hormones whilst they figure everything else out. There's also the things about what that does to your body and if it starts to revert and how body fat moves around. And even as you potentially lose weight during treatment, how that can affect someone's gender and lead to gender dysphoria. So there's so many nuances to it that I think often get overlooked because, without sounding mean, it's just ignorance. I think a lot of people just aren't really either meeting these patients enough or having these conversations enough, or as Lizzy pointed out, just not being taught. There's no core kind of curriculum on this. So It really is in the position, exactly. We are pushing, I promise. And actually, that's a point, like, as a charity, we're creating one that will be an accredited course. So we want to put this information in it and really, I think, celebrate our experiences. You know, like, even when I listen to you, Tatum, talk about your experience, it's sobering, you know, and there's so many of us out there who feel like we don't really get an opportunity to share it, whether that be in the doctor's office or in the support group that's very straight, or in all these other spaces. And I'm glad that our charity can start to make those, but there's so many voices out there that I think we're yet to hear.
Yeah, and I think that's the thing is, you know, cancer is already this really divisive, sort of corrosive, and you know, what we were talking about at the beginning, almost like can encourage disassociation from our bodies in order to get through treatment. So it becomes even more necessary to bring your whole self to the rest of it, whether that be your support, whether that be your medical team, because actually, in order to come back together as your whole self, and you know, there needs to be that integration. So we've touched on psychosexual therapy a couple of times. So I want to ask Lizzy, what is it? What do they do? I mean, it sounds, you know, like when you look at it, it's like psychosexual sounds like someone you'd want to avoid, not someone you'd want to seek out. If you're into that. What do they do?
I'll be honest. I am not 100% certain, as in I have never had psychosexual therapy myself. So when we make the referral, it's a group of specialist therapists. Ours are actually at Leeds oncology trained psychosexual therapists. So they are psychosexual therapists who specifically have the knowledge of cancer and the impact of cancer on people's sexuality. And it's basically a toolkit of therapy techniques that they have that they will help patients basically recover the sexuality that they want. And that can be physical in terms of different tools, like different sex toys, like Stewart mentioned earlier. And so they can have a variety of things like the O-nut, they might suggest to people, or it might just be certain types of vibrators, non-penetrative vibrators. So things that can help encourage sensation for people with vulvas. As Stuart mentioned earlier, people often have quite negative issues with touching and things after surgery, negative connotations with that area after treatment. So actually rediscovering pleasurable sensations in that area again. But also just a look at people's psychological, talking therapy around sex and their desire cycle and what type of sex they want. There's something called responsive desire. So we always sort of think the way society works is that we should have spontaneous desire. We should just randomly become horny and have a libido or whenever, and ideally that will be at least 3 times a week. Somehow that's just become the sexual script that people expect. And actually a lot of evidence shows that responsive desire is more normal for most people. So that's when you actually have to sort of cook up the atmosphere and the context for having sex. And then that often will be like, oh, actually now I'm horny, or now I have a libido, as opposed to just expecting it to just arrive. And with them, often many cancer patients suffering as a side effect with fatigue and a lack of libido and sex drive, that can be a really important thing. I think something that many people hadn't occurred to them before, that they might need to foster that environment for sex as well.
Yeah, thinking about that is so interesting. Like having a place that you can talk through like what, you know, where does arousal come from? What do, you know, and how it might look different now. I mean, possibly you could even find some things that you never even did before. Like
absolutely, yeah. I've had the pleasure of interviewing 2 different psychosexual therapists, and one of them described reconnecting with your sex like a buffet. So it's this idea of just really just experimenting, trying little things, you know, whether that be sort of metaphorically from head to toe on your body, or whether it be from activities you've always wanted to try. And it's just this idea of just getting some exploring back in there. So it brings in a bit of excitement. It allows you to reestablish what sex looks like. You might discover something new you're into. If you're fortunate enough to be near a good sex shop, you can go in there and actually take a look, get to know some textures and understand what feels good for your body. And also always make sure, if you are exploring buying toys or lubricants, make sure you get high quality things. It's worth it to spend that little bit of extra money so the body's safe, especially after cancer treatments where the skin might be open and sore. You really want to make sure there's no bacteria that's sort of residing on those, and make sure you clean toys in between use and do these things that make sure you can be healthy and happy.
I hadn't thought about that with the cheaper ones, but actually that makes a lot of sense, doesn't it? I do know for Yes is like the one that all the doctors recommend.
Yeah. And because some lubes as well, they can have too much sugar in, which can be bad for your body. And then also some toys you might buy online from sort of a cheap retailer because you want to save a bit of money. The latex will be really low quality or just not correct. And there's a tool or a test you can do. I think it's something about boiling latex. Latex should be fine, so you can almost sterilize it that way, but other plastics can't. So there's these things, and some really good reputable places to look for. Obviously, Shush, the female sort of led queer shop, the sex shop, which is a good one. Spectrum Boutique in America. Even if you can't access the toys directly, they have a really wonderful approach about discussing sex very openly, which led me to discover things like the Laurel's panties, which are dental dams in panty shape. So if you're having issues with incontinence, it means you can still engage in oral sex without having to worry about that. Fantastic, right?
That is amazing. I've never heard of that. I'm so happy. I'm learning so much.
and there's other ways you can be creative as well. It's the idea of get creative. Like there's, you know, it's about understanding what does it for you. And it might even be clothing. It might be environments. You might want to try having sex in different places. So there's all that kind of stuff. But also Lizzie and I were talking before about Tenga, and you can get these sort of textured eggs. And normally we think of them as sort of tools for people with penises and masturbation. But you can also flip them inside out and put them over like a Hitachi wand or a Doxy wand. So there's all these different ways you can just ultimately just see it as a playground and just get that idea of the sexual buffet in your head. And the other thing to reflect on with these conversations I've had with psychosexual therapists is they're some of the most frank conversations you'll have. Yeah. So if you've been struggling to have these conversations with your other clinicians, don't take that fear into that appointment, because that's the appointment where you can just say everything. And even if they don't fully deal with people who have the same kind of sex as you every day, they won't shy away from it. They'll ask more questions and want to know. And then the other final point is, in addition to psychosexual therapists, if you feel like actually what you need is relation therapy, so it's this idea of actually I've kind of called my body, not too much has changed, but actually the way I connect with people is very different. Yeah. There's also sort of relationship therapists you can usually get prescribed through the NHS as well, or you can find privately. And not all psychosexual therapists do both. So it's just making sure who you're going for, make sure that if they're doing the relationship side or the sex side, or if you've got someone that can sort of handle both.
Yeah. You know, I went into a sex shop recently and I hadn't been into one for a number of years because reasons, because I thought that part of my life was done. Oh my God, there's so much good stuff that isn't as scary as it used to be. Like, I remember it just being all like black and spiky and, you know, kind of uncomfortable looking, just peering in. Now it's like, I mean, whoa, silicone has like changed everything. I know I'm really behind the times. I appreciate that. I've been out of the loop for a while, but I'm now back in. And
on that, one of the best things that's come around recently is these clitoral stimulators that are pressure pushed or air. Like they're really wonderful non-penetrative toys, especially if you've had a reduction in sensitivity. Like they are fantastic. Lizzie's nodding a lot, so I'll let Lizzie explain.
Yeah. So would this have been one of your recommendations for a toy?
What? I've not actually recommended it to a patient yet. But I think it's worth a try, especially if maybe you don't feel like penetration, because rather than vibration, some of them have a vibration setting as well. They have a suction end. and you can actually change the size of the nozzle usually on both of them, on most of them. And then what it does is it applies like air suction to the clitoris. And most people find it a very intense orgasm. So people have been writing rave reviews about it, and people who have never managed to sort of orgasm before, absolutely loving it. So I think it is probably something worth trying for people who are wanting to try something a bit different, maybe need, maybe especially if you've lost sensation in the clitoris or you feel that you're struggling to orgasm. Honestly, these guys are strong. You will get a lot of sensation from this. It might be something you want to work up to. If you're feeling a little bit sensitive in the area, you might want to start off with like a Tenga toy that's just sort of for the vulval area, more of a gentle vibration, and then work up to it. I mean, they do have loads of settings, to be fair, so you could start off with a really low setting on it.
Tell me the name of it again. I'm writing it down.
So Womanizer is one of the main brands that does it.
Okay.
Honestly, really, really good.
Okay.
So sell them, the shop that Stewart mentioned in London. So they obviously have their actual shop in London, but the website ships anywhere in the UK. And they're amazing. They're really good as well because they sort of describe, I think the byline is a women's sex shop, but it's very inclusive. They do sell toys for all genders. They have a specific trans non-binary range. They have a specific sort of lesbian section. There's a beginners section. You know, there's very much like it's arranged according to what type of sex you might like or what kind of things you might want to try.
So if you're into the spiky things, you can go into the spiky section. And if you're like me and like quite liking the colourful silicone ones, okay, that sounds really good. That sounds like and you know, that's one of the things that I've heard is that kind of going back to that hormonal disruption and the different ability to have or to come to orgasm, that I've heard that, you know, for people that have maybe never used sex toys before, that, you know, some people have shied away from that for various reasons, that actually post-treatment, you might need more input than you did before. And that it might be a really good time to explore that. Going back to like where you were, you know, because I think some people kind of feel like, oh, I don't need anything but my partner, you know, that actually this is maybe a time, you know, that's totally fine. But if you do find that you're needing your partner to do a lot more work, that, you know, knowing that there can be changes in that, I think is quite useful.
Yeah, and a lot of the toys are really specifically the sort of created to be used with your partner. I mean, obviously, there's lots of things out there, like different kinds of strap-ons, different dildos that are very much like to be used with a partner. But even like some of the vibrators, you know, you get like double-ended dildos too with vibrators in. There's all sorts. And it's that idea of, like Stewart was mentioning earlier, consent, having that discussion with your partner, sort of working out what's going to work for both of you, but sort of getting your partner to understand what you might need that's different. I think maybe I'm overgeneralizing, but I do think that people who have queer sex are good at that already because there is no societal script on how to have sex. So you're basically just working it all out anyway. And this is much more mutual satisfaction usually aimed for than perhaps in traditional heteronormative sexual scripts. And people are quite used to mutual masturbation or, you know, watching their partner use a toy or vice versa, or doing that together. That obviously it's just that it's a good way to just think anything's possible. I can try anything. There will be something out there. Just have a browse, have a look.
Yeah, it's I heard someone say recently that a sex therapist said if you haven't used it in 3 years, basically you've lost it. And they were absolutely heartbroken. And yeah, I think that this conversation is definitely like, you know, being queer, we've already got one leg up in terms of being that bit more creative. And I suppose it is a way of how you communicate with your partner or a new person of like, I now have a sexual buffet available. Yeah. Like maybe there is something that I'm now not doing, but I have this other, platter, this smorgasbord of other things, and kind of thinking of it that way. I suppose it brings that fun back into it, doesn't it? And brings it back to fun and pleasure and feeling good. And, there is that processing of a loss of what maybe wasn't there, but also looking forward to what can be there.
Yeah, and I wanted to sort of bring in just one thing we haven't touched on yet, which is the idea of shame, which kind of still exists around sex a bit, and I think Lizzy points out that I think queer sex is usually a little bit better on this because we talk about consent a bit more, and what you said about mutual masturbation, I think, is also such a key thing that probably happens more with us, and we know there's obviously studies that shows that lesbian sex is usually more fruitful, let's say, than heterosexual sex.
Yes, we don't know when to stop.
Yeah.
It can go on for weeks.
Apart from the 6-hour sessions with pauses for snacks and
6 hours.
I was about to say 6.
But it's this thing, isn't it, where we're speaking in a very free way, and we'd hope that a lot of people in the community would get that, and even people who potentially are outside the queer community but listening in and want to kind of understand what they can pull from our experiences to improve their sex lives. And I think one of the really strong things is to combat shame. So don't feel ashamed about masturbation, for one. And don't let your partner feel any kind of shame or make you feel ashamed if you decide to bring in a sex toy. That sometimes there's this kind of weight that the partner has to be everything, like Tatum said, and that's just not the case. And it's never really the case, but it might especially not be the case after cancer. And it might be that case of, okay, to explore myself, I have to potentially get over the idea of shame from myself and my culture that says masturbation is not okay. And really exploring that and really unpicking these things that I think we get sort of told subliminally in the world around us about how sex should look and what's appropriate, but actually really reviewing and thinking, well, what feels good for me? What can I do to explore this, either with someone alone or with multiple people? As Tatum said, it's not about moving back to where you were and the kind of sex you were having. It's more about exploring and moving forwards.
Yeah. And doing that free from shame. And, this is not always easy. I mean, I didn't get help because I felt shame. And, and I was someone that, was I did a queer talk show, back in the day, and, talked openly about sex. And, there's a show floating around the world where I'm holding up a sparkly silver dildo. I was very open. I was open with extra sparkly open dust.
We need more of that on TV, Tate, to bring it back.
Yeah.
It was on TV in Canada. But so I was there, and then it's very easy to shut down into shame. And, if this helps anybody, it can be a bit of work to get out of there, and it's not always easy. But, I think, what helped me was hearing some quite older men that had had prostate cancer getting very upset that they couldn't have sex. And I was like, I'm in my 30s and I'm not complaining like that. You're in your 70s. And then I was like, oh, yeah, there's something wrong with this picture. Right? Other people allow themselves to get upset if they're not able to do it, because there is a sense of, I should be able to have this. And if that shame has been internalized, there is a sense of well, that's it, Yeah.
And there's the age part there that you brought in, this isn't just young people talking about it. And obviously that's who Shine primarily works for, but it's everybody. And if we go back to right at the beginning when Lizzy was talking about these quality of life measures and is it really looked at by healthcare? I've met so many times urologists where they say, 70-year-old woman with bladder cancer, well, we don't need to ask her about sex. You absolutely do. If my nan's anything to go by, you absolutely do. So yeah, sex doesn't have an expiry date.
I'm very happy to hear that. And is that your experience, Lizzy, with working with people? Have you known people to have active sexual lives later than we expect?
100%. As Stuart said, I mean, I've met older women who just sort of look at the dilators and think, oh, I've got something much bigger at home. You know, it's not, age is definitely not something that should stop someone from having that sex life or wanting one. And there are plenty of people out there who are having one and want to. And we don't discriminate by age and the information we give to people about dilators. We just think we'll give it to everyone and they can do with it what they want.
Yeah. And just, you know, I could talk about this all day. Like, both of you are fascinating. And I feel like I've learned a lot. And those panties, that just kind of blew my mind. Right. But I one of the things that does come up is comfort. And I think that's like definitely something, like, if you're not comfortable doing it, like, that is something that's quite tangible to tell your team, you know, and especially when it comes to vaginas, you know, and post-cancer, they, you know, again, no one tells you that if you don't have enough estrogen, that things can shrink and atrophy, and both internally and externally. And the thinking on topical estrogen has changed. So now even people with hormone cancers are being able to have topical hormone. It's very low dose. It's so low and it doesn't go into the bloodstream, but in that area. And again, it's like, it's that comfort. So if you're not, and it's something that only ever, like, it never gets better by itself. Like, you need some treatment or like need some, you know, what's it called? Moisturizer in that area. And so I think those things, yeah, are quite tangible. Like, you know, obviously you want to tell your partner, but also that's something that's quite tangible to tell your medical team, and definitely worth getting advice about it, because you want to be comfortable, happy, hot, sexy, creative, and a full platter, you know? So,
yeah, absolutely.
If that's
and
what
safe
you want.
as well, you know,
Safe.
like, it's the idea of, you need to have good lubrication, and with that come with topical estrogen and stuff like that as well. So you're less likely to damage the skin, especially if you're post-treatment, and that skin can be more sensitive and thin as well. So it's that idea of sex should always feel good. And I think it goes back to what we were talking about before about consent, but it should be enthusiastic consent. You know, it's that idea of, am I ready? Do I want to do this? And it may feel weird in the beginning, and it may be a bit of figuring it out. We're not saying you're going to be gung-ho from the first time. There may be some slight bit of trepidation, but it is that, exactly like you said, it's all those factors together.
Brilliant. Thank you so much to both of you. Lizzy, did you have one other thing that you wanted to mention?
Yeah, just as a consent thing, I think it's that thing as well, even if, or whatever point you're having sex, if you change your mind and you're like, actually, this doesn't feel good, and actually I'm totally out of it, and I don't want to do this anymore, like, you just say to your partner, that's it, like, I want to have a break, or I don't want to continue. I think, again, people sometimes feel like they're obliged to be started to carry on until that your partner's satisfied, rather than yourself and how you feel. So I think, that's really important. Yeah,
it's coming up with a communication, isn't it? Because I know for me, like, I didn't want someone to worry about me, but I wanted to instill in them, I will. And I did tap, like, I literally tapped out, you know? So it was like, go for it with a strap on, like, as you would, proceed as normal, and I will let you know, and I promise you I will. Yeah, you want that enthusiastic consent, but it's like coming up with a code between the two of you of, like, if anything changes and it's no longer comfortable, how do you have that conversation in the midst of it? And there is some thinking to not using words can be useful, because some people, like, will take those words really, really personally. So sometimes it is like a tap and a kiss, you know, that it can be a kind of more loving signal than needing to stop and have a full, you know, discussion in the middle.
Oh, I think that's such a wonderful suggestion, because the idea of safe words can feel so foreign to people. The idea of just saying, like, banana in the middle of the sex, that's supposed to stop it, you know, and because that's what we see on TV and what we hear is the correct way to do it. But I think you're right. Just making sure that there's good eye contact, touch, clear signals, and communication throughout is that really good way forwards.
Yeah. Thank you so much to both of you. I'm sure people are going to have some questions. You can, if you want to, actually, Stewart, if you can say where to find you.
Yeah, sure. So Live Through This is my charity. You can find us on socials at LTT Cancer, and that's where you can get in touch with us too. We do peer support monthly online for patients, and we're just launching it for carers and partners as well. We talk about all these things very openly in a mixed gender, mixed tumor group. And if ever you need to sort of pick my brains personally, you can get at me through the contact form on the website.
Oh, wonderful. And thank you, Lizzy. And I think all your patients are really lucky to have you as their radiographer.
Hopefully, I'll try my best. We've got a good team at least.
Brilliant. Well, thank you to Lizzy and Stewart, and thank you to Radio Facilities for supporting our podcast. We love them. And thank you to all of you for listening. If you like us, please subscribe. And the reason for this is that it gets more eyes on us, and more eyes brings in more people who realize that actually they could do with talking to someone and could do with some more help. So hit like, hit subscribe, follow. It really does make a difference. Thank you so much, and we'll see you soon. Bye.